Good afternoon, everybody. Is it audible? Okay, at the outset, I'd like to thank AIOS and TNOA for giving us this opportunity. My topic is on surgical management of keratoconus. So indications for surgical intervention would be patients with very advanced keratoconus, extremely thin corneas, patients who are intolerant to contact lenses, poor visual acuity with glasses, unmet visual requirements and expectations, patients with severity and progression of keratoconus, location of the cone, and the presence of scarring or a previous eye drops. So surgeries for keratoconus are very many, but we're going to go through one by one. So this case one was a patient with advanced keratoconus, and what I'm doing here is I'm trying to identify how much the cone is extending by putting some fluorescein, and then now I'm measuring the cone so that I can decide what will be the trephine size. And in this case particularly, we had to take an 8.5 millimeter trephine to encompass the cone. And after making an initial cut, I'm just making a small cut, and now I'm using a 30 gauge needle to inject air into the stroma to get the big bubble. So now I'm decompressing the anterior chamber. This is very important. Otherwise, when you're de-roofing the bubble, the chances of upthrust and the Descemet's membrane getting ruptured is very high. So you can see that the air is escaping, and now viscoelastic is injected into the space between the stroma and the Descemet's. And using a blunt varnish, we make 4 quadrants and cut the superficial layers to expose the Descemet's. So at this point, it's very important that to make sure that the bubble is extended up to the area where you have done the trephination. If not, you have to be very careful, because that's a point where you can inadvertently perforate the Descemet's. So now you can go all round and remove all the areas which have been separated, and now you can get a nice exposure of Descemet's membrane. And at the same time, making sure that you're going along the area where you already made the trephination, so that you'll keep to the exact size of the trephine that you have chosen. And once you have done this, you also have to make sure that there is enough area for you to suture. So use a second instrument and just make a small dent, so that it will give you some idea where to suture. So this is a slightly oversized graft, of 0.25 millimeter oversized graft, and I'm using 16 interrupted sutures to complete the case. So in cases with advanced keratoconus, sometimes a big bubble may not be possible. In this situation, that we may have to do a manual DALC, or sometimes even convert it into a PK. So this is a post-op of the same patient, and these patients do extremely well because of volume building, and also because the quality of vision goes up, and they might need a selective suture removal if the sutural astigmatism is very high. The next case I'm going to talk to you is about a keratoconus with inferior cone. As you can see that the patient has a cylinder of 3.75, but topographically is almost 6 diopters. And similar, you can see topographically a astigmatism of 4 cylinder. So in this case, we decided to go ahead with a KS, or a corneal allogenic intrastromal ring segment, which is basically a volume building procedure, and it acts like a belt and compresses the cone. So it gives some amount of refractive effect also, and reduces the amount of astigmatism and gives more symmetry to the central area of the cornea. So here the trephine size we have used is 6.5 to 8 millimeters to create this double trephine. Allows us to make the case segment, and the femtochannel dimensions are 4.6 inner diameter and 7.1 outer diameter, and the depth of the cornea is about half the thickness plus 50 microns, which is around 300 microns. So this is how the femtosecond channel is being created. This is a femtosecond laser. You can see that the channels are larger than what we would normally do for an intact segment, and it has also created the incision. Incision is usually made at 0-180, and I'm using a wide spatula to open out the channels that we have created, and also using a trypan blue marker to know till what area that we have to introduce the segments. So, and then the segment which has already been prepared, which is de-epithelialized as well as endothelium has been removed, is inserted into the channel which has been created, and the excess is trimmed off. You can alternately also make another incision in the opposite side with the femtosecond itself, and you can even pull through instead of pushing through. Sometimes if you have a large segment, you might have to do it, and keep pushing so that you make sure that the segment comes up to the area where we plan to do the case. That is somewhere between 4.5 to 8.5 clock hours. So this is a post-op of the same patient. You can see the patient landed up with a +1 cylinder, and in both preoperative K1 and K2 showed a drop in cylinder of at least 3.5 to 3.8 diopters. And this is a comparison map done at 1 month and at 3 months, showing an excellent response to CARES. This is the AIOS2025 showing the presence of the CARES segment. The next patient I'm going to discuss about is a patient who underwent intacs. So this patient had a mean spherical equivalent which was very high, which was 4.5 and 7.5 cylinder. So in these cases, it's always better to go for 2 segments, one inferiorly as well as one superiorly. And the incision is usually made in the steepest area of the cornea, contrary to what we do in CARES. In CARES, only an inferior segment is placed. There's no superior segment placed, whereas in patients who are undergoing intacs with high mean spherical equivalent, we do place 2 segments. And in this case, we plan to place a symmetric 0.5 segments with an incision at 130. And this is how an intacs is done, and 2 segments are being placed. The first segment goes in quite easily, whereas the second segment, because already some space has been occupied by the first segment, may be a little bit tight, but it is still a doable procedure. And what happens is when you it produces what we call as a reduction of the arc. So the arc shortening effect is how the intacs work, and thereby they produce some amount of symmetry in the central portion of the cornea. All these patients have to be counseled that whatever we do, they still may have to wear spectacles or contact lens. And after this, you can continue this with the collagen cross-linking. So these are some of the results. This is the patient which I showed you, 7.5 cell has dropped down to 4.5. This is again the next patient who had an asymmetric segment, and the cylinder dropped from -4 to 1.5. Here you can see that the amount of the comparison map showing a difference between the A and B, showing the amount of correction that is there. So the other surgical indication for in keratoconus is a management of acute hydrops. Normally, acute hydrops is managed only medically, but in cases of very advanced hydrops, we plan to do a compression suture. Here, an inferior PI is created, and air is injected into the anterior chamber to tamponade, and 10-0 nylon suture is used to create the compression suture. Usually the suture starts at the clear cornea, that is the area between where the hydrops is to the clear zone, and you apply multiple sutures. It need not go through and through, it can just go even partial thickness. The advantage is that when you put a compression suture, the stroma is made more compact and makes it much more easier for the Descemet's membrane to come back to its original position. And in the long term, this also prepares the eye to receive the keratoplasty earlier. Unfortunately, if you just leave it like this, it takes quite a long time for the edema to resolve and makes the patient very uncomfortable. As you can see here, the edema is resolved and the Descemet's is back in its position. So the compression sutures work, like I told you, as full thickness, can be partial thickness, compresses the stroma and helps in fluid absorption, shortens the edge of the DM tear, helps in earlier resolution of the edema, prevents corneal neovascularization, and prepares the eye for early surgery. So this is a case of keratoglobus which came to us about 2 years back, and you can see the map had a thinness PACU of 203. Though we advised DALC at that point, patient was not willing. But subsequently, 2 years later, she came with this presentation. She was complaining of watering and irritation in the eyes, and you can see that on doing a CDLS, there's an area of perforation with a micro leak. So the cornea has become so thin, it started perforating, and the keratoglobus was from limbus to limbus, and she underwent a full thickness penetrating keratoplasty with the limbus to limbus graft. And her uncorrected visual acuity improved from 636 to 612. So this again, the last case I'm going to show you is a case of PMD, or pellucid marginal degeneration. There are different surgical modalities which have been suggested. One of the latest is that is of a tuck and lamellar keratoplasty, where a full thickness penetrating keratoplasty or a DALC can be done, but it is tucked into the, a groove is made all around and it is tucked into the groove. The reason being that prevents the stem cells being removed because of the full thickness, full amount of the limbus being destroyed. So even in this case, though we have done this, you can still see an area of persistent epithelial defect, which we had to deal with using autologous serum, and finally he healed only with lateral tarsography. So summarizing, surgical options should be considered after non-invasive management such as specialized contact lenses. Intakes and cares are good options for moderate keratoconus. There are several stromal augmentation procedures which are becoming very popular, like basement membrane transplants. And in patients with advanced cone and extremely thin corneas, DALC is the best option. PK can also be considered in patients with dense scars and post-hydrops. And ectatic conditions such as PMD, keratoclobus need specialized procedures with increased skill levels. Thank you.
Thank you so much, madam. It's a very wide range of amazing and exhorting surgeries. For somebody who doesn't see corneal surgeries regularly, it was really an eye-opener. Thank you so much, ma'am.
Any questions from the audience regarding how to manage keratoconus surgically?
Actually, I have a very fundamental doubt, ma'am. The first case you showed, DALC, you said you gave us a few instructions so that we can avoid a small perforation of the thing. In case you perforate, what would you do?
It's a small perforation. It's a small perforation. You can continue to
No, mic
It's
is
not
not
audible.
No.
both are equally bad.
Yeah.
Okay, if it's a small perforation, we can continue to we can put in air and continue gently all round and suture it. Usually, if you take care, what happens is nothing will happen. Otherwise, you can go for a double anterior chamber because the aqueous can go into the interface. So that is one problem. But if you have a very small break, even a moderate size break, we can still continue because it's important that we retain the Descemet's membrane of the patient, because in the long run, that is more beneficial to the patient.
Thank you. Any other questions? Anybody?
Yeah. Go to Murli Arika next.
Yeah.
Yeah.
Yeah, you can.
Yeah. Thank you, Sujatha, for the wonderful talk on the surgical management of keratoconus, which is very, very important.